with respiratory and alveoli and stuff. I didn't really get very far last time. I don't know why. I took it easy. So we have to just pick it up a little bit this time. So we finished here, I think. And the last point that I made on Wednesday was that when you breathe out, the alveoli don't collapse. And they don't collapse because of a special substance in them, or coating them, called surfactant. Surfactant is a lipoprotein, a surface-active compound, which lowers surface tension. So the issue is this. Did I use the balloon analogy last time? Yeah, the bit about hard to get something going when it's completely collapsed. So you don't want them completely collapsed. And this is what the physics looks like. If you have two balloons connected to one another, then the pressures in them, in the absence of any surfactant, the pressures in them is governed by this equation here. The pressure in these balloons is governed by 2 times T, which is the surface tension, over the radius. So if the surface tensions are the same without surfactant, if the surface tensions are the same, then the pressure in B is much bigger than the pressure in A. So if you have alveoli of different size, when you exhale, the air will be forced out of the small ones, both out and into the big ones, they're caught like this arrow here, and the small ones will collapse. And that's bad news. So what you have is this substance surfactant covering them, and it's an interesting topic. You have to do a term paper topic this term, I think. I'm going to set a term paper topic on surfactant. I haven't decided what it's going to look like yet. Okay. So if you're interested in this, you can have a chance to go into it in a bit more detail. If you have surfactant, then the surfactant coats and changes the surface tension in these balloons depending on their size. And so now the tension in A is larger than the tension in B, so you have low surface tension here, and then the pressures become equal. So you manipulate the T on the top here with surfactant to equalize the pressures in the large and the small alveoli, and so there's no flow from B to A. They both collapse at the same rate. And so regardless of the size, you have equal emptying. And this becomes, the only time this really becomes an issue is if you don't have surfactant. And the only time you don't have surfactant is if you're a premature baby. Surfactant forms very late in development. When premature babies are born, they're often born without enough surfactant in their lungs. And so their alveoli are very hard to inflate. Surfactant, fortunately, is a relatively simple compound. So it's a lipoprotein secreted by those special cells in the alveoli called type 2 cells. And when it's spread on the surface, it reduces the surface tension, allowing uniform and easy expansion and emptying of the alveoli. And so premature babies have little or no surfactant, and what they do now is they simply have synthetic surfactant, and they pour it in, and that helps the babies take their first breath. So it is an issue. This is called infant respiratory distress syndrome, and it's actually one of the leading causes of death in premature babies, because they can't get their first breath. So here's a word, the collapse of alveoli is called atelectasis. So that's quite an interesting topic. I haven't got any more time than this to talk about it, but if you're interested, I think I'll put in a term paper topic on surfactant and how it works. Any questions on that? I'd like to move along a little bit with these early slides here. They're all sort of interesting little side topics to respiration before we get down to the real topic of respiration, which is gas exchange. Mucus and cilia. There you go, I got mucus. All passages are kept moist by mucus secreted by another set of cells in the airways called goblet cells, and their responsibility is to secrete mucus. You need it moist because the gas exchange occurs with the gases in solution. So the gases, the oxygen dissolves in the moist environment and diffuses across that way. But also the mucus traps small particles, and all the lining cells have cilia, which can keep the mucus layer moving. You remember cilia, these hair-like processes on the surfaces of epithelial cells, and they wave like this, and their job, you like this? Their job is to move a layer of liquid on the surface of the epithelia, and many of our systems, the epithelial cells have cilia on them. The female reproductive tract, the fallopian tubes, the epithelial cells have cilia which waft the oocyte down the fallopian tubes. So lots of the epithelial compartments in the body have cilia which move a fluid layer over the surface, and in this case, the cilia keep the mucus layer moving at about 1 centimetre a minute from the depths of the lungs out towards the pharynx. So the mucus then you either or you swallow it. And so this eliminates particles from the lungs. And if you smoke for many years, you wake up, all the cilia go like this, and you wake up in the morning and they haven't been doing their job, and smokers wake up and they cough for about half an hour when they first wake up to cough up all of the mucus which has trapped all the particles and would normally be working continuously but didn't work during the night. And so that's called a smoker's cough, another good reason not to smoke. Here it is. So look, this is a scanning electron microscope, a micrograph of the surface of the airway epithelium. I'm not sure which region of the airway epithelium this is, but you can see it's covered with these hair-like processes or cilia which wave, and they conduct the mucus layer from the depths of the airways out towards the outside on the surface of the airway tubes. So that's just a simple cartoon showing what I mean. Okay, while we're on the topic of mucus, I need to show you this. Not because of all these channels, that they drive you insane. I'm not here to talk about all these channels, but you know about channels and how important they are in the transport of ions and small molecules. And airway epithelia are no different. They have a whole slew of channels moving sodium, chloride, potassium, calcium, all the usual suspects. But in the airway, there is a special channel up here, and it's a chloride channel conducting chloride ions outward, up here. And it has a special name. It's called CFTR. And the net result of all of these ion movements, and in particular CFTR, is that it affects water movement. Now you know water follows sodium and chloride, and by moving sodium and chloride ions particularly, you can affect water movement. Well, if you don't have this particular channel, water movement doesn't occur properly. And the mucus, instead of becoming watery and easily moved by the cilia, becomes thick and sticky, and it clogs up the lungs. And this condition is called cystic fibrosis. And CFTR stands for cystic fibrosis transmembrane conductance regulator. CFTR for short. So CFTR controls the liquidness of the mucus. And if you don't have it, as I say, the mucus becomes very thick and heavy and isn't cleared properly by the cilia. So you have this overproduction of thick, sticky mucus caused by a genetic defect in the chloride channel of the epithelium. Question, yeah? The water follows the chloride through different channels, I think, because it's not only the chloride channel that's controlling water movement, it's the other ones as well. So the sum total of these controls water movement osmotically, but that one in particular, if it's not there or if it's screwed up, water movement is messed up. And this is an interesting Canadian story, because the CFTR channel was discovered at the University of Toronto by Dr. Lapchi Sui only in 1989. And of course this was brilliant because it gave a genetic cause for cystic fibrosis, the reason for which was previously unknown. And so here it is, the CFTR activity normally results in electrical gradient, blah, 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 sodium chloride. Due to this movement, the movement of water is affected by osmosis, and so you don't have the fluid mucus that you should have. And also, incidentally, if you don't have CFTR, other epithelia are screwed up as well, because the same channel is present in other epithelia, but it doesn't have quite such devastating effects in other epithelia as it does in the airway if it's missing. And so if you can't clear this thick mucus, there's repeated infections, fatal damage to the lungs, and these unfortunate people die quite young. And this is an obvious target for things like gene therapy. I don't want to go into this area, but if you could repair this gene or replace the gene or have something else which would secrete and insert CFTR into the airway epithelium, you might go some way towards fixing this problem. And obviously there's a lot of research being done in CFTR, particularly in Canada. It's an area of research which is quite strong here, trying to fix CFTR, which is cystic fibrosis. So that's quite interesting. So that's mucus and the issues associated with it in cystic fibrosis. A couple of other quickies here. The bronchi and the trachea are very sensitive to irritation. You know, don't you? I mean, you take a swig of beer and it goes down the wrong pipe. You're just coughing for 20 minutes afterwards, trying to clear it out. And so the trachea is very sensitive to foreign materials. And so it initiates what's called a cough reflex. And think for a second what happens in the cough when you cough. I'm going to cough. First thing I'm going to do is close the epiglottis at the top of the trachea. I'm going to increase the pressure in my thorax, so close, increase the pressure, and then release the epiglottis, and it comes out. So you close it, you increase the pressure, you open it, and you get an explosive outrushing of air, which hopefully carries the beer out with it. And so that's a reflex that happens when you cough to clear particles and whatever else you've got in the airway. And the sneezing is the same thing, except it's not here. You expel the air largely through your nose when you sneeze. So coughing and sneezing reflexes are designed to protect the airway, and much of this is designed to protect the airway. And the airway is so important. If you've ever done first aid, for example, or if you've ever done a first aid course or a CPR course, the first thing you have to do if someone's in trouble is to protect the airway, make sure that the airway is open and they can breathe. And so in protecting the airway, there's a lot of built-in mechanisms for doing this. So, for example, the issue is every time you take a breath, You inhale all the junk that's out there, all the pollution, all the particles, all the bacteria, all the viruses, they're all going in. And so the lung has significant protective mechanisms built in. And so here they are. First of all, the lungs produce their own antibodies. You remember what the antibodies and antibody structures are? Immunoglobulins. And the most common one in the blood are what? IgGs. Do you remember that? But there are other Igs as well. And the lungs produce their own kind, called IgAs. And these are designed specifically to resist infection. I haven't got time to talk about that, but it's an interesting topic. In immunology, if you're doing any immunology, you would get to talk about this. There are pulmonary macrophages, which phagocytose particles and bacteria. And if you remember on a picture I showed last time, and I'll show again in a minute, you can see the diagrams with the macrophages in them, which phagocytose. The cough reflex is another protective mechanism, and the ciliary reactions of mucus and transport. So multiple mechanisms for protecting yourself against inhaling harmful materials, particles, bacteria, viruses. So the lungs have their own mini protective mechanism. Here's a table of useful terms I found. Incidentally, I have to say something. These pictures that I'm showing, I should have actually put up a slide right at the beginning last time, which I forgot to do. These pictures that I'm showing, some of them come from your textbook, you'll have noticed. Some of them don't. And so what I've done is taken what I think are the best pictures from different sources. And the university is very worried in the last year or so about copyright issues. Have you come across this before in other courses, perhaps? Right. So I have to say to you that I am showing you a limited number of pictures from other textbooks, below the level of which I infringe any copyright. I mean, if I were to Xerox a whole book and show it to you and you are allowed then to run it off, that infringes copyright. But the amount that I'm showing is okay, and you can run it off, and you can learn it, you can use it for your own personal study, but you can't run it off and sell it on Jasper Avenue. That would infringe the copyright. So, so that's my copyright statement. You can use these pictures for your own study, but you can't. I don't know who would want to buy this on Jasper Avenue, but anyway, there you go. So anyway, look, I found this. Quite interesting, quite a handy little dictionary of terms. I'm going to let you go through these terms on your own, but just when you look down these terms here, just remember that almost all terms, you can figure out what they mean from the structure of the word. So these first ones here all have pnea on the end. Can you see? Hypopnea, dyspnea, apnea, tachypnea. Anything with pnea or pneu, it has to do with air. So it's like pneumatic, you know, pneumatic tires, pneumatic drill, they all work with air or compressed air. So anything with pnea or pneu is air. Hyper means too much. Hypopnea is increased ventilation, for example, when you're running. That is called dip. Anything with dip in front means abnormal. A in front means not. So apnea means no breathing. Tachy. Do you remember tachy from cardiovascular? Did you? What's that? What's tachy? Tachycardia. Yeah, fast. So tachypnea is fast, rapid, shallow breathing. Hyper again is too much, hyperventilation, hypoventilation, hypoxia, deficiency of oxygen. Hypoxemia, anything with emia on the end is blood. So you come across other words with emia on the end. We'll come across some when we do kidney. So hypoxemia means too little oxygen in the blood. Hypoxemia, too little oxygen in the blood. This one's not readily apparent. Capnia, anything with capnia in it has to do with carbon dioxide. So I'll let you go through those. If you have any questions about them, email me or bring it up in class next time. Just a little dictionary of some of the terms that I'm going to use during the next week or so. All right. Any questions? You okay? Pretty straightforward stuff. So we talked a little bit about this last time, but this leads into the next topic. And the next topic is work. You're not thinking about it while you're sitting here quietly breathing and thinking about what you're going to do over the weekend, but you're actually doing a fair bit of work to get the air in and out. And you have to do this work because you've actually got a lot of tissue to move every time you take a breath in. Every time you take a breath in, you've got to move all these ribs, all these muscles, all the lung tissue, all the cartilage. There's a lot of stuff to move. And so you have to do work in order to do it. You remember last time I said that in quiet breathing, inspiration is an active process, and expiration is a passive process. It's a passive recoil. And I'm going to come back to that this morning as well. And so air enters the lungs. When the pressure in the thorax is lowered by expanding the thorax, you breathe in, you expand the thorax, you expand it, the pressure goes down. Pressure goes down in there, air is sucked in, piece of cake. You also lower the diaphragm. The diaphragm is a sheet of muscle underneath the ribs, and as I said to you, you need to do work in order to do this. And the diaphragm is this dome-shaped sheet of muscle, has a paired nerve going to it called the phrenic nerve, one on each side. Here's a diagram of what's going on. Here is the chest wall with the intercostal muscles here, and so if you eat spare ribs, you're eating intercostal muscles. Yeah, you like spare ribs? Plate spare ribs, what you're gnawing off the spare ribs are the intercostals, right here. And these are responsible for inspiration and forced expiration. And inside the lungs here, and each lung is sitting in a sac. And the sac is called the pleural sac. And it's composed of two membranes called pleurae, one attached to on the lung side and one on the chest wall side, and it separates a space. And that space there is called the intrapleural space, or the pleural cavity. You see it? And it's important. I'll show you why it's important in a minute. So that's what's going on with the chest wall and the pleural cavity. Okay. And here is the nerve and muscle activity, cyclic, when you breathe in and when you breathe out. So quietly breathing, as you're doing, inspiration is active, expiration is passive. So here it is. Here's the phrenic nerve, innervating the diaphragm. Every time you breathe in, it fires, and then it's silent when you breathe out. Breathe in, fires, silent when you breathe out. Here are the external intercostal nerves, active, spiking when you breathe in, silent when you breathe out. Breathe in, breathe out, breathe in. The internal intercostals, those are the ones closer to the sternum, are silent because the internal intercostals have to do with expiration. And expiration is passive, and so there's no activity. So here is the muscle tension here in the inspiratory muscles. That's the external intercostals. Contract, relax, contract every time you breathe. The expiratory muscle tension, that's the internal intercostals in here, are silent. And here is your lung volume, in, out, in, out, in, out. So it's quite nicely reciprocal innervation or firing of the nerves. When you force breathe, then the expiration is active. Remember I talked about this last time. And so in that case, you're forcing air in and you're forcing air out. So as you force air in, the phrenic nerve's more active than before, the external intercostal nerve more active than before, and now the internal intercostal nerve becomes active for the expiration. You see, inspiration, silent, inspiration, silent. Here is inspiration, active expiration, inspiration, active inspiration. So expiration. So inspiration is going on as before, higher than before, because you're forcing the issue. And now the expiratory muscles are also getting involved as you force air out, like this, in and out. So this is called active ventilation and quiet breathing. And the lung volume is larger. So, you know, if you're running and you're breathing heavily, then this is what's happening. If you're sitting quietly in class, then this is what is happening. Okay? Question? Good. Okay. So, this business of increasing the volume of the chest by raising the ribs and lowering the diaphragm has the effect of changing the pressure inside the lungs. And this little picture here is all about the pressures that are involved. So that's the next little topic I'm going to talk about for 5 minutes, are the pressures that are involved when you breathe and how the pressures change. First of all, atmospheric pressure. You know about atmospheric pressure out here at 760 millimeters of mercury. But it doesn't change. So for respiratory physiology, we're going to reduce it to 0 and talk about all the other pressures with respect to atmospheric. Do you know what I mean? So, explain what I mean in a minute. So, we'll consider atmospheric pressure as 0, and everything else is plus or minus atmospheric. First of all, the alveolar pressure, the pressure in the alveoli. You expand your chest, the pressure in the alveolar goes down, air rushes in. Alveolar pressure. We'll have a look at that in a minute. Intrapleural pressure. That's the pressure in that little space between the lungs and the chest wall. Have a look at that in a minute. It's always negative. I'll show you why in a minute. And then the transpulmonary pressure is the difference between the alveoli and the pleural space. And I'll show you that as well. So the next 4 slides are illustrating this one, and this one. It's easy. Watch. Alveolar pressure. Here it is. You breathe it. You breathe in. You breathe out. The alveolar pressure goes down. The alveolar pressure goes up. Not by very much. As you breathe in, the alveolar pressure is reduced by 1 millimeter of mercury. So this is with respect to atmospheric. So it's 1 millimeter of mercury less than atmospheric, and air rushes in. As you breathe out, the lungs, the chest wall recoils passively. The pressure increases in here. Now 1 millimeter of mercury above atmospheric, so air rushes out. It's very straightforward. So air in, air out, and the pressure in the alveoli goes down as you breathe in and up as you breathe out. That's an easy one. Here's the intrapleural pressure. The intrapleural pressure is the pressure in that space where the pleural sac is. So here's the lungs. If you leave the lungs on their own, they will recoil inwards. I'll show you what the effect of that is in a minute. Here is the chest wall. If you leave the chest wall on its own, it will recoil outward. So you've got the lungs tending to collapse in, and the chest wall tending to come out. What you get in the middle is a negative pressure. There's a vacuum in there. And the negative pressure is always at least minus 4 millimeters of mercury. And you see the space in there between the lungs and the chest wall is negative. Always, it's about minus 4, but it varies. I'll show you in a minute. And the effect of this is to keep the lungs expanded. If you've got the lungs sitting in essentially a vacuum, they will stay expanded. So what happens if you destroy that vacuum? Here you go, down White Avenue on a Saturday night, have a drink in the back door, and you go out the wrong door. And you come run into some guy in the back alley, and he takes your wallet. Puts a hole in the chest wall and destroys the minus 4 in your pleural cavity. Your lung collapses. Look, here's the minus 4 here. Keeps the lung expanded. You destroy the minus 4. You take away that vacuum, and the lung does what it will do if it's left on its own, and that is it will collapse. And, you know, so you rush to emergency, and they sew you up. And the chest then does its thing, which is tends to expand, and the lung is beginning to do its thing, which is tend to contract, and it gradually re-establishes the minus 4 there, and your lungs re-expand. And it can happen not only through a stab wound, it can happen spontaneously for various reasons that I'm not sure what the details are, but the emergency pulmonary people, I see this from time to time, collapsed lung. And the collapsed lung is because you lose the minus 4 in the pleural cavity. Is that okay? Anybody ever had a collapsed lung? It's not that uncommon. It's quite uncomfortable, apparently. Yeah. Your brother did. There you go. It's always someone in the class. Yeah. What happened? He wasn't stabbed on White Avenue, I take it.
No, a grenade went off near him and shrapnel pierced him.
Say again?
A grenade went off near him.
Oh, he's a soldier or something like that?
Yeah.
As the grenade went off, a piece of shrapnel pierced his chest wall, collapsed his lung. Is he okay?
Yeah.
They sewed him up, and he got his minus 4 back, and his lung re-expanded.
I got my minus 4.
Good.
Oh gosh.
Okay, and so the final picture, you can go through this one on your own actually. Look, here it is. Here is this is the transpulmonary pressure. Here's the pressure in the alveoli. Do you remember? Minus 0 to minus 1, 0 plus 1, cycling like that. As you breathe in and out, so the intrapleural pressure, that minus 4, actually changes slightly and goes, look, from minus 4, minus 6, back up to minus 4. So as you breathe in and out, the pressure in the pleural cavity changes slightly. And the transpulmonary pressure is the difference between these two. It's a measure that you can use. And so you can follow this. Physiologists love these things. I'm sure you've seen them before. These flow charts. It makes nice sense if you go through it. So I'll let you go through that. Yeah.
So you're saying that you can do a flash happening randomly. Like on these doctor shows, you can see them like re-expand ones by seeing like or something. So how does that like work?
Where do they stick the needle? Oh, they stick the needle in the pleural cavity and suck air out. So it helps to more quickly reinflate the lung. They're not actually putting the needle in the lung, they're putting it in the pleural cavity to suck the air out of the pleural cavity, which will re-establish that negative 4 and re-expand the lung. But it will happen on its own, apparently. If you just sew it up, it will gradually re-establish the minus 4 on its own. But I guess they do that to help it, to evacuate the space more. What's this, House you've been watching? I hate House. It all happens in the last 5 minutes, you know. Come on. But I think you put 1 hour show. Anyway. Okay. Pressures, done. Any questions on that little bit on pressures? We're still not down to the gas part. Need to talk a little bit about work, this business of work that you do. The work of breathing, it's called. Work equals force times distance. Remember that from physics? So the force now is the pressure that you have to apply, the change to inhale. And the distance moved is the change in the volume, and you can measure these. And the ease with which you can get air in and out, which when you're young is not an issue at all. You don't even think about it. But unless you have an issue with airway diameter, which I'll just talk about in a minute. But the work that you have to do to get the air in and out depends on a number of factors. And one of them is called airway flow resistance. So if you try and blow into a tube, if you're blowing into a very narrow tube, you have to blow hard. If you're blowing into a very wide tube, it's easy. So that has to do with the resistance of the air in the tube to flow. In a narrow tube, the air becomes turbulent and much more difficult to force air through than if the tube is wide. Normally not an issue. Where does it become an issue? Asthma. Yeah, next slide. We'll talk about that in the next slide. The other issue is elastic work. So think about this. You're forcing air in, you're expanding the chest, you're expanding the lungs. The more elastic the tissues, the easier it's going to be. And there are conditions in which the elasticity changes, becomes even more elastic or less elastic. And this issue of elasticity is called compliance. The word compliance or compliant means flexible, elastic. And so compliance is an issue that I'll talk about for a minute or two in a moment. And finally, there's something called inertial work, which I'm not going to say anything about, but you remember what inertia is from physics. There's a little bit extra force required to get something moving from a stationary position. And so getting the system moving takes a bit of extra work, but physiologically not an issue. So the next few slides are about work. They're about airway flow resistance, and they are about elastic work or compliance. Are you okay? Are you with me? I'm going a little bit faster today. Are you with it? You can put your hand up and ask me to slow down if you want. So look, this is just again the picture of what it is you have to move and what you're working against. You're working against moving all this stuff. And so here are the external intercostals. Those are the ones responsible for inspiration, and the diaphragm as well, inspiratory muscles. The internal intercostals, the one closest to the sternum here, are the expiratory muscles. And so these are the muscles that are doing the work. They're muscles that are doing the work, and they're the muscles which you have to move in order to do the work. And so here, as you breathe in, you enlarge the chest here. See how large that is in comparison to that one. You expand the chest wall, and you lower the diaphragm. And here, expiration, the chest wall, cavity contract, and you raise the diaphragm. We've talked about that before, but it just shows you what it is that you're working, what your work is doing. So airway resistance then. Do you remember on that table that I showed last time, some of the airways had smooth muscle in them. And we said that that indicates that there can be contraction going on. So that's an issue here. Because if you contract the airways, the diameter's going to get smaller. And if the diameter gets smaller, you've got to do more work in order to move the air in and out. So the primary determinant of airway resistance is the radius of the tubes. And adjustments in the airway size are accomplished by the autonomic nervous system. I remember someone said that last time. And the autonomic nerves regulate the airway smooth muscle, the tone, the mucus secretion, the vascular permeability, the blood flow, and the influx and activation of inflammatory cells. It's what the autonomic nervous system does, as you heard about last time. So sympathetic stimulation causes bronchodilation by promoting smooth muscle relaxation. So here you have somebody with asthma. Asthma is caused by inflammation and reduction in the diameter of the tubes, and it increases the work of breathing. So a normal bronchiole, an asthmatic bronchiole with inflammation, contraction, narrowing of the tube. So people having an asthma attack, I'm not going to ask, but I'm fairly sure there'll be someone here that has asthma greater or less to a greater or lesser extent. An asthma attack, you can't get the air in the tubes quickly enough. So a lot of people with asthma will carry around a puffer, and you've seen people use a puffer with epinephrine in it, which is a smooth muscle relaxant to relax the smooth muscle in the airways, to widen the tubes, to lessen the airway resistance and lessen the amount of work that they have to do in order to inspire air and expire also. We'll talk about that a little bit also in a bit. There's also parasympathetic stimulation, which promotes bronchoconstriction, that would be affected by acetylcholine. But I'm not aware of any conditions or issues where there is normally bronchodilation, where you would have to bronchoconstrict. But the other one, the first one, is very significant in asthma. Yeah? Okay? And asthma's a big deal. Asthma's a big deal. We have a big pulmonary division here in the University Faculty of Medicine and the hospital. A lot of pulmonary docs, a lot of pulmonary research, and there's a big area of research on asthma. It comes about because of the immune system issues, and is very significant for the pulmonary people here. It's a very common cause of people showing up at the emergency department. Let me just start on this other topic for a few minutes before we quit today. Where are we going here? We're here, yes. So airway resistance, flow resistance is important, particularly in something like asthma. What about this elastic business of compliance? Let's just define compliance and have a look at it. So here is compliance. This means the elasticity of all the tissues, the ease with which the lungs can be inflated. It's an important clinical measure. So while I'm talking about what goes on in the hospital here and pulmonary, there is, if you turn up an emergency or go to your doctor with breathing issues, one of the places that they might well send you is a lab in the hospital, all hospitals have them, called the Pulmonary Function Lab. And so in the Pulmonary Function Lab, there are people who specialize in making measurements of people's breathing efficiency. The Pulmonary Function Lab. I'm going to talk about it next time. There's a whole fleet of people in the hospital, which you don't really hear very much about, called respiratory therapists or respiratory technologists. Very important job. They're right there with nurses, with physiotherapists, occupational therapists, radiation technologists, a whole area of expertise just in respiratory. And they are the ones that are responsible for operating the ventilators for babies and other people that need respiratory help. They're the guys in-house, what you see intubating, you know, you're shoving the tube down and they can't get it in and all that stuff. They do that. And they do measurements. And we're going to talk about measurements next time. But one of the measurements that they do is compliance. So you can measure compliance, or how elastic your lungs and chest wall are. There's a normal figure for it. 0.2 liters per centimeters of water, delta V over delta P, determined by the stretch of the tissues and the surface tension in the alveolus. So the stretch of the tissues, that means the muscles, it means the lungs themselves, and it means the alveoli as well. And so normally, again, when you're young and healthy, compliance isn't an issue. But if you're 60 years old and you smoke for 50 of them, then you remember what the issue is with the alveoli? You destroy the walls between the alveoli. And so people with this condition called emphysema smoked for decades, destroyed their alveoli. They can't get enough oxygen transmitted across the wall of the alveoli because the walls are shot. But what they have is, because they don't have very many alveoli, it's easy to get air in and out. They're not putting air into alveoli, they're putting air into big spaces in there, non-functional spaces. And so people with emphysema have very high compliance. In other words, it's not difficult to get air in and out. The problem is, once they get the air in, they can't exchange the gas out of it. So they're gasping for air, not because they can't get it in and out, but because once it's in, it's not doing any good, and they still have hypoxia, not enough oxygen in the tissues. The reverse can be the case, a very low compliance, in other words, low elasticity, because when you damage tissue and it repairs, it doesn't usually repair with the same tissue that was damaged. You know this. If you cut yourself and you look a year later, you've got a scar there and you can see it. And scar tissue is not the same as the original tissue that was damaged. And scar tissue is not elastic. So if you have a lot of scar tissue in your lungs for various reasons, a condition called fibrosis. Fibrosis is just lots of scar tissue. It's very difficult to inflate your lungs. So people with fibrosis have very difficult time inflating their lungs. Their compliance is very low. People with emphysema have, it's easy to get the air in and out. Their compliance is high, but the gas exchange is not good. So I'm going to stop there.